Welcome to part 3 of our little mystery series here, the conclusion. We're going to hear some answers, finally. So what do we know so far? The patient is a 50-year-old man. He has no medical conditions at all. He doesn't take medications. He's seen 2 glaucoma specialists and an optometrist. He's heard from 2 of them, well, 1.5, that he has glaucoma, and therefore he received a prescription for eye drops to reduce his eye pressure. He met another glaucoma specialist who'd said, no, this doesn't make sense. The optic nerve looks totally normal. And we also looked at the photo of the optic nerve, and I agree, they look totally normal, at least given the context of being a nearsighted person. And then we looked at the retina. We found that the retina looks on the whole pretty average, but then once we switched the lighting to black and white, to a fundus autofluorescence, we found that there are whole sections of the retina that are thin and missing. And indeed, we demonstrated that with an OCT scan of the retina. We found that the fovea and the area around it looks pretty good, but then around that, it looks really thin and abnormal, and this is affecting both eyes. We also know that in his family, there's no missing vision really at all, aside from the fact that everyone's really nearsighted. So the differential diagnosis, or a list of potential things that could be causing this, really involves only 2 things. One of them is a retinal dystrophy, that is an inherited retinal problem, and the other is a low-level inflammatory condition that could affect the retina slowly. Something like cancer-associated retinopathy or melanoma-associated retinopathy, a paraneoplastic condition where the immune system gets so active and angry about a cancer that it affects the retina. Or a rare infection like syphilis, for example, could cause this. If we think about dystrophies, what are we talking about? A genetic problem. Something like retinitis pigmentosa could cause this, and there are various manifestations of it. For example, something called retinitis pigmentosa sine pigmento, in which case we don't find all of the normal classic findings of bone spicules and big pigmented things. Instead, what we find is no changes really significantly of the pigmentation, but we know that the person has retinitis pigmentosa. So how do we evaluate this? Well, we did a bunch of imaging in labs. He doesn't have any inflammation or an infection. I can show that in spades. Instead, we rely on genetic testing. Here, my friends, is the answer. This is a genetic test that I offered to the patient. Check it out. What does that say? RPGR. This patient has a mutation in a gene called RPGR. What does that stand for? What does this do? RPGR stands for retinitis pigmentosa GTPase regulator. It's an important protein in the function of photoreceptors. This patient's photoreceptors are not acting normally. They're becoming atrophic. The patient is developing retinitis pigmentosa, and it was a thing that convinced a bunch of people that he has glaucoma. He doesn't have glaucoma. This is a really tough diagnosis. I don't blame anyone for being confused. It's very subtle. I'm just glad we took care of the patient and we got the answer we needed.